I'd like to start by thanking Professor Anuradha Lohia for this kind invitation. I actually feel quite awed to come and speak at a university which is 200 years old, but I've known her for some time and she's an amazing person. If you can make an organization like the DBT Welcome Foundation grant function and function efficiently such that an investigator can get his money on time, that projects are reviewed properly and funding given appropriately, I think that's no mean task. And I am pretty sure that as Vice Chancellor of this university, she will deliver those skills to make this university better. Thank you, Anuradha. Bala, thank you for those kind words. Actually, after I came to Calcutta 6 years back, I realized that this is and has been the center of science for a long time in India. In my own field of hematology, the first proper stain of a blood film was from Calcutta, when Leishman first described how to do a stain. The disease Kala-Azar was first described in Dum Dum, which is where your airport is, and where Dum Dum fever was first recognized as being due to an organism and was described as Kala-Azar over here. In my own field of hematology, there have been great people who worked on hemoglobin E and many other blood disorders at a time when there was no hematology, so to speak of, in the rest of this country. My brief in the next few minutes is to try and take you through medical education. Actually, the title should have been Making Medical Education Relevant to the Challenges of Today. Let us not talk about tomorrow. And that is actually one area where I would like to cover in this Global Education Summit. And the outline of my presentation is first, the need; second, the selection process; third, the course content; fourth, the evaluation process; fifthly, assuring professional standards, the whole issue of governance; and lastly, and actually most importantly, mentoring and values. India has one of the lowest doctor population ratios in the world. Even Pakistan is better than we are. And we believe that there is probably one doctor for 2,000 of our population. And this is the map. And surprisingly, the country which has the best doctor population ratio is Cuba, which is 1:170. The US is 1:390, Pakistan is 1:400, and we are 1:700. How has Cuba managed it? To provide one doctor for 170 of its population, of its patients. And Cuba does this by, the first thing is that medical education is free. So you don't pay for medical education in Cuba. Secondly, all graduates who pass out have to serve the community for 2 years. And thirdly, which is most importantly, you do not have in Cuba that a cardiologist will get paid so many lakhs, while a primary physician gets paid less. So the incentive, which is money, to go into specialization is not as powerful in Cuba as it is in the rest of the world. So that's an amazing way of social medicine meeting the needs of the population. In India, in 2017, there are 412 medical colleges, which fit 52,000 medical seats. And importantly, 26,000 of these seats are in the private sector, not in the government sector. The probability that if you apply for medicine, that you will get into a medical school in India is 0.4%. I'm not sure what it is for the science and the humanities. I think it's better, but in medicine, it's in fact quite dismal. Now, medical education as a commodity started with the advent of capitation medical colleges, where private medical colleges were charging a huge fee in order to get into a medical college. And this is in fact with the introduction of a national selection for entry, the so-called NEET exam, has resulted in private medical colleges massively increasing the fees that they charge. This is the number of postgraduate seats, and again, sadly, we do not have enough specialists in different disciplines to treat our population. Now, one of the major things that we need to consider is the selection process. How does a student get into this 0.4% who make it to a medical school? This is Ida Sophia Scudder, the person who started the Christian Medical College in Vellore, of which I am an alumnus. And this is the hospital, and this is the medical school. We have a beautiful campus, 400 acres, and it's quite a privilege to study there. Now, the selection process in Vellore is actually quite amazing. There is an MCQ examination, and the large part of that MCQ is not physics, chemistry, biology. It is problem solving, the ability to try and answer a question. Now, after you qualify in the entrance exam, you go through a medical test to see whether you're fit. Then you have a series of 2 days. One is individual tasks. There are 20 tasks. Some of them are impossible to finish. So you should know quickly which task you cannot do, which task you will be able to finish within the time that is allotted, and which you think you have better skills to do quickly. Simple things like threading a needle, threading 10 needles or whatever. You'll be amazed at how the faculty come up with ways of testing the student's ability. The second is a group task. And in the group task, you're in a group of 10 and you're asked to build a bundle. And there are people watching you. And you find this guy who's so destructive of anything happening together. So when I showed a video of this in Australia, my colleagues there said, "Mammen, did you have to do all this to get into medical school?" So I said, yes, in fact I did. And there of course are interviews to look at aptitude. The University of Newcastle in Australia was so impressed with this selection process that they decided to experiment with that. Sadly, this is not the way selection happens in our country. These are the top 10 coaching institutes. I don't know how many students here went through one of these coaching institutes, right? And believe you me, some of these places, you go there and for a year you're in prison. Your cell phone is taken away. From morning to night, you sit and cram MCQ questions, right? And then you try to crack this IIT JEE exam. This is a coaching class in process in Kota. And would you believe it? Kota is a 300 crore industry where coaching happens for a fee, and the fee is huge. So from the 9th standard, parents are pushing their kids, and much more so in Kolkata than anywhere else, to try and aspire to get into an engineering or a medical college for a kid who really has no interest to do medicine at all. Why? Because money is the driver. And that is the sad state of the selection process. We really have to make some change in the way we select students. Innovation is required, problem-solving ability is required, the ability to work together. You're actually coming into a humanity when you come into medicine. And if you don't have that ability, then you really shouldn't be there. So the first thing we really need to address is the selection process. And what do we have at the end of it? We have a burnt out student. He studied for these years or 2 years to get into medical school. All drive, all ambition, all initiative that he has is gone. I come in the morning at 8 o'clock to take a class on the platelet, which to me is the most fascinating bit of biology. A 2-micron thing that prevents you from bleeding to death. And this guy is sitting in the class with bleary eyes, couldn't be bothered about what I'm talking about. That's sad, no? That all drive and all initiative has been taken away by the process of selection. And this is something that we really must address. Coming to content, which is the second major thing, I believe that medical schools need to relook at the content. The first is, how much do our students understand the reality of medicine in a village? And this was enunciated as far back as 1946 by the Boer Committee, which said that India is predominantly rural, with 80% of its population in the villages, and our doctors must know what the realities are of practicing in the village. But there are problems in placing them in the village, and all of you know that in any primary health center in our country, the doctor comes for about 3 hours and then he's gone away for his private practice. Now, what we did at Vellore was that we started a COP program. The student actually stayed in the village for 2 weeks during the first year of his undergraduate curriculum. He stayed in the village, and this happens at 2 points in your curriculum where you actually stay. And it's actually great fun, if you tell me, to actually understand how a village operates and how you can intervene in order to change what happens in a village, and this has been extended in many ways. How did this happen? It happened because the faculty were interested in making a change, and this change was implemented wholeheartedly by the institution. And this is an example of the COP program, with students actually sitting outside of a village hut and seeing what happens. The second is to teach students how to problem solve, not just to learn by rote. Unfortunately, these coaching classes don't teach that. They teach you only how to answer those multiple choice questions that will come. And I'll give you a beautiful example, which was a talk given at Tata Medical Center a week ago by a visiting plastic surgeon from Singapore. Identify a clinical problem, formulate a hypothesis, and do something to prove that hypothesis. We must never forget that medicine is a science, and this is the foundation of science. To ask a question, and this is how you go down formulating the problem. Now, what was his problem? There is a flap called the latissimus dorsi flap, which is taken from the back in order to fill up a defect if you've resected a tumor, and this is the anatomy of the flap. What was the problem? A large number of these flaps were necrosing, and the failure rate was as high as 80%. Now, this is a necrosed flap. You've taken the skin flap with its blood vessel, you've rotated into the neck, and you've connected up a 3 mm blood vessel with an operating microscope. If you've done your job well, that flap will survive. If you haven't done it, it will become black, the skin will necrose, and the patient has a huge amount of deformity. So it was considered at that time that the dorsal scapular artery was the most important artery. The transverse cervical artery was the most important artery. So what did this guy do? He went into the laboratory and asked, what is the blood supply of this trapezius flap? Right? So he went into the lab, he started looking at it, and he found that in fact the dorsal scapular artery, which nobody ever thought was important, was more important than the transverse cervical artery for supplying the blood supply to this flap. And he did this with painstaking dissections in the laboratory, injecting the blood vessels, the dorsal scapular artery, the transverse cervical, and showing that in fact this was the dominant vessel and that you need to connect this when you put it back. He even looked at the skin territory of the blood supply, and this is all done on cadavers in the anatomy lab. I was really amazed when I went to the anatomy department in Calcutta Medical College. It really looks like 1850, right? And it's just absolutely amazing. So what he found out was that the dorsal scapular artery is the dominant supply in 80% of people. And in fact, he then started moving it to the clinic, and he showed that now you could prevent graft failure and graft necrosis by this operation. The success rate was 96%, and these are the questions he asked, and these are the answers that he found out, and at the end of that, he said no research is complete till published. 3 major publications which showed that this technique is better than the transverse cervical artery. Now, can we make our medical students ask questions, formulate hypotheses, design experiments? Now, this is the anatomy laboratory in Singapore University. It's as good as any of the operating theatres in India. And you can see the sort of work that can be done in an anatomy laboratory. So we need to really think out of the box as to what we're going to do. Thirdly, are we fitting our medical students for the science of tomorrow? This is Peter Nowell and David Hungerford. And in 1960, they found out that tiny little loss of chromosome 22. You and I would never have even noticed it. They noticed it, and this was epoch-making, because this was the first description of a non-random genetic change in human malignancy. And this is the paper they published. The whole paper, mind you. When you have something great to tell the world, you don't need a lot of words, right? And that was the full paper which was published in Science on what we call today the Philadelphia chromosome. This is Janet Rowley, who said that it wasn't a deletion of chromosome 22, but a translocation between chromosome 9 and 22. And we subsequently know the downstream pathways which are triggered when this translocation occurs. And this has resulted in our understanding of how to diagnose, how to monitor, and how to treat. Today, I don't do a bone marrow for a patient who comes to me with chronic myeloid leukemia. I do a fluorescence and cytohybridization. I can get the diagnosis in 48 hours. We monitor the disease with a nested PCR, and we then are able to track the disease at a molecular level. This is Donald Thomas receiving the Nobel Prize for medicine for his science of stem cell transplantation. Today, I don't transplant a patient with chronic myeloid leukemia because of the understanding of the molecular biology, and this has moved to the discovery of a small molecule by Brian Drucker, who moved it to the clinic, and we now have something which will switch off the translocation and make it dormant. So you now have converted a malignant disease into something like diabetes, where you pop a pill a day and live your life normally, right? So this is data which shows the long-term survival. However, cancer cells are not simple. They acquire mutations. We can identify the mutation today, and we now have second targets which we can use to track and inactivate the mutation. So we have changed carpet bombing into sniper shooting by the science of genetics applied to the clinic. I think that question was asked to Partha in the morning, and without any doubt, this is happening. It's happening here in Calcutta. It's happening in India. I was so pleased when on Saturday we had a symposium where I have a patient with a young lady with hemolytic anemia. But it didn't look right. Something was wrong. She had a cousin with congenital dyserythropoietic anemia. 2 different spectrums, one where there's a failure of red cell production, another where there is increased destruction. Send off the genetic material to MedGenome. I get a report saying that SEC23B mutation has been identified in the homozygous form in this patient. Discovered, proven. But there is another spectrum 3 which may or may not be a mutation. So when my students described all about genes being conserved, all about whether the probability, the in silico prediction, it just made me so happy that we have students now who can translate the science of molecular medicine to a patient whom we are seeing. This is the EGF receptor, and these are the pathways through which you try to block this in various cancers. So we are now in the era of molecular medicine. And are we training medical students to understand how genetics is impacting almost every part of clinical practice that we have? Next, about the evaluation process. Now we have a clinical exam and we have a theory exam. You pass the theory, then you come to the clinic. And in the clinic, you will get 2 short cases, you will get a spotter, and you will get a long case. And honestly, I don't believe this system of evaluation is good at all. We need to have a better way of evaluating competence, and I'll come to that in a minute. These are 3 examples where competence was questioned in the United Kingdom. A lot of deaths when cholecystectomy was done laparoscopically without superstition, without supervision. There was a Harold Shipman inquiry of a physician who was giving morphine to his patients, and there was the Bristol cardiac surgery inquiry. And at the end of this, they said that there isn't enough governance to say whether a doctor is fit to do what he is currently doing. And we need to improve that to see how it happens. Small example, a new trial where they were looking at a sentinel node biopsy. They actually got surgeons who were going to do this to come and train and showed the percentage success rate before they were allowed to operate. So, as patients, many of you may be patients at some time, you would certainly like to know that your doctor is proficient in what he's doing and able to do. And that's where we are really sad, in governance. The Medical Council of India, the less said about it, the better. We do not have a proper system of governance to ensure that people who are trained are adequately trained. I still remember my professor of surgery telling me once there was a candidate who appeared 7 times in Tirupati Medical College for the MS in general surgery. So his local professor said, please pass him, let him go. Because they had just had enough of him hanging around. So they said, by Lord Venkateshwara, do you swear that you will not take the scalpel? If you agree to that, then we will pass you. So governance is crucial in a field like ours. Lastly, I want to say a few words about mentoring and values. Now, I feel this is where medicine in India is falling down. We are coming into a corporate culture where the student is only looking at when he can buy his BMW, when he will move into the bracket of those who earn. Yesterday I was reading that Tim Cook's salary is coming down by 10%. And what is that 10% coming down? From $2.5 million a month, it's coming to $2 million a month. Can you imagine that? Right? So sadly, medicine is moving down that pathway where the mentoring is based on what you earn. I was fortunate in having a mentor in this physician called Dr. Benjamin Pulliam. He really taught me what it was to be a doctor. And I'll give you one example more of a classroom. Professor Jacob John was taking a class. I was a very impetuous student. I got up, it was on toxoplasmosis. So I asked him, sir, have you seen a case of toxoplasmosis? Because I hadn't seen. So he looked at me and he said, Mammen, I will ask you a question. Have you seen an iguana on the college campus? So I said, no, sir. said, please look. And a few weeks later, a huge big iguana was found in the men's hostel. So what was the message? I'll never forget that message. Don't say something doesn't exist before you've looked for it. And these are the teachers and mentors we need to tell us how to go about the profession we are entering. Medicine is an art, and that is where medicine and the humanities meet. Knowing how to communicate, breaking bad news. There's a beautiful book called When Breath Becomes Air. It's written by Paul Kalanidhi, who was actually a literature student before he decided to do medicine. And he was a neurosurgeon when he got cancer. And it's a beautiful book. I would recommend reading, right? Knowing how to communicate. You know, the problem I face in my own institute in Calcutta now is trying to tell doctors how they must communicate. And it's very evident to a patient whether you care or you don't care. So if there is no empathy, then you're really not fit to be a doctor. You, yes, can go into laboratory sciences, even in medicine. But if you want to deal with people, there must be empathy. There must be the ability to treat the patient as a person. There are no working hours. I believe in the UK now, a doctor will leave a sick patient at 5 o'clock because his time is up. When I was a student, there was no working hours. My professor of surgery would sit on the culvert outside the hospital drinking tea with me because I was on roster that night. That was the mentoring I got. You never left a patient till he either died or he became stable. Is that the value that we teach our students? Working as a team. The most destructive thing in medicine today is individual ego and how destructive it is to a team. How do we teach people that working with each other, we can build a better community, a better hospital, a better facility for patients who need care? Thank you very much.
Mesmerization is not enough. Ask questions.
I think all of us are completely mesmerized with our energy. Ask two questions. How would you translate this from medicine to all that you see around you? Because a lot of what you said at parallels in what we observe as education. And I think our challenge now is really in the future is to bring about actual mentorship, not just in name, but successful mentorship. And clearly the rules will have to be different, the tricks will have to be different, the approach will have to be different. How you and I got mentored is not going to work anymore. How do we take them away from their BMWs? How do we tell them to care for each other? Because values have changed.
You know, Anuradha, I personally believe that a student will only believe that something is important if he sees it in the people who teach him. And therefore, I still believe that students, I can say many things, but they will see it when they're doing around with me. And they will realize my hypocrisy when I'm doing around with them. So there's no way in medicine that a teacher, he'll be caught out immediately. So I don't think that that's important. But to have enough of people in medicine who think this way is important. I believe you have 300 students in life sciences. So I was talking with your faculty, and I think it would be nice, because we have an MOU with the Presidency University, whether in batches of say 50, your life science students can come and spend an afternoon. We can take them through the different disciplines, from imaging to say nuclear medicine to laboratory science. You know, I recently did an interview for a person for a faculty position in IIT Kanpur. And he was a life sciences guy. And he was working in the Wallace Coulter Laboratory in California. I asked him who was Wallace Coulter. He couldn't tell me. So I said, my God, you're working in the Wallace Coulter laboratory. You don't know what Coulter's contribution was to science and to medicine. All our electronic counters today are based upon the Coulter principle, right? So I really think that it is possible, even today. I'm very pleased. As I told you, Saturday morning session at TMC was such a pleasure for me to sit and listen to the students who were making these presentations. So I don't think we are lost. I think we'll get there. We just have to have enough people who feel that it's possible. And I want your life science students to actually think. You know, there was a presentation before mine by David, and I attended last year in the Indian Institute of Management in Calcutta, an entrepreneurship program run by the Tatas. And I was amazed. There were students from MIT who had applied for the award. There were students coming up with projects on what to do with flowers that are given in a temple. Beautiful, you know, that students were thinking, these flowers, what can we do with all these flowers? Okay, it's given to God, but surely something more can be done with it. So I think in India we're slowly moving, not as quickly as you are there, David, but to understanding that entrepreneurship in any field of medicine, be it life sciences. There was a guy from physics who was talking about a defibrillator which can work in a village just by cranking it up. I just couldn't believe the sort of ideas people came up with. Thank you.
So I'm in a dilemma. This is the penultimate talk of the day, and the day began almost by saying that we don't need classrooms. On the other hand, penultimate talk, you're saying that your mentor is sipping tea, sitting on the culverts of CMC because you are on roster and you're trying to treat a patient who hasn't stabilized yet. That's my dilemma. And if I say a little bit more about Cuba and about the kinds of things that you said, I'll be branded a communist. So where is the gap going to be filled, or how? I mean, here are two completely different mindsets. I don't think Mr. Vivek Kumar is here, who almost said that we don't need classrooms anymore because the technology will replace classrooms. On the other hand, we are talking about a humanitarian science where mentorship is so critical for the value system to be absorbed by the student. How do we bridge that gap?
Honestly, Partha, I would say it's extreme to say that you don't need both. I absolutely believe some of the best knowledge that I have retained. Of course, you need teachers who are not just going to give you facts. You need teachers in the classroom who will take you where your mind would not have wandered. And I still believe that didactic classroom teaching is important, but I also believe that the field where we learn our experience is just as important.
Do you think that the Indian medical education suffers because of the young age of the entering medical students?
That's a brilliant question because, you know, I had a person from the US who brought 6 of his students from California to just see what I'm doing. They came to my office at 4 p.m. I had a child with Fanconi's anemia and his donor. Now we know Fanconi's anemia is a disease of DNA repair. And you know, they didn't leave me till 8 p.m. because the way the mind took them in hundreds of different directions, I just enjoyed it. I don't know whether the students who come into medicine today, in fact, I am more pleased to give a talk to a science audience of university students than to give to medical students. We have somehow lost it, and I think they are burnt out. So we need to look at the way. But I won't say that the system will not prevent an individual from coming through. And what I saw on Saturday in my own hospital was two very average students who have just done brilliantly. So I think if we provide the environment where they will think, where they will look at questions, ask the right questions, they will come up. I don't think the system can destroy an individual.
Dr. Chandy, we extend our warmest thanks to you for your lecture. We would like to present a token of our gratitude. I'm sorry.
Sir, actually it is very unfortunate, but many of the doctors, tend to mislead the people for their own interest in BMWs and all that. So do you think that there is a need for a kind of need for a public education on basic medical services and all? I mean, the general public to know how the basic things work, so that at least they can detect.
I agree with you that having people who know helps me as a physician, but I also have the other example. I had a material scientist from Ford. His mother had lymphoma, she had fever, and I come on rounds, he's got his computer open, he's Googled all about her fever, and he tells me, "Doc, don't you think we should treat her for malaria?" So I say, "Pal, this is where you get off." Okay? So, yes, having an informed patient and us as doctors doing as much as we can to help the patient understand his disease, because I think understanding is the best way to conquer fear. And I, for one, believe that all my staff should spend as much time talking and explaining about the disease to the patient. Thank you.
Pertinent question to Mr. How do we really tackle the information explosion in the medical field? I think that is one of the important reasons for burnout amongst the medical students. In fact, I am a faculty teaching in a medical college to hear your lecture. And this is one of the burning issues in the medical fraternity, how to deal with the knowledge explosion, because the doubling time of knowledge has come down to like 0.2 years. At 2020. It was around 50 years in 1950. It's all because of knowledge explosion. How do we tackle it in the medical education system?
I think that's an important question, and I think that those of us who structure curriculum, see, I designed the DM in hematology in India, because India did not have a super specialty training in blood diseases. I was the one who put the course content together, to put the evaluation system in place, and it was accepted by the Medical Council of India. So all of us who have a responsibility must try and see, and the most difficult is structuring an undergraduate curriculum. I just picked out 3 areas to show where constantly we need to be changing the course content in order to make it relevant. It's not an easy thing to do, it's very hard.